Hello and welcome to our first session in this special on-call series, a collaborative approach to a chronic care problem, evaluative results from the Atlantic Healthcare Collaboration. Today we will be exploring results and lessons from CFHI's Atlantic Healthcare Collaboration, a pan-regional quality improvement collaborative for improving care for patients with chronic disease across the Atlantic provinces, to inform strategies for designing, implementing, and evaluating quality improvement collaboratives. I'm Megan Roster and I'm pleased to be your host today. We're happy to be joined by more than 180 registrants for this series from across the country, including, of course, representation from our East Coast provinces, as well as Ontario, Quebec, BC, and our remaining all of our 10 provinces. We're pleased to be providing simultaneous interpretation for today's call for a Francophone audience. As I introduce our speakers, please take a moment to introduce yourselves in the chat box, who you are and where you're from, as well as any questions you have for today's speakers. So joining us today, we have Donna McCausland, who is the Primary Healthcare Program Development Lead with Community Health of Health PEI, which includes primary care networks, public health and home care, geriatric and palliative care programs. Much of her current work is about building primary care and chronic disease prevention and management through collaborative relationships, team building, integration of services, and frontline training coordination. We had the pleasure of working with Donna and her team at Health PEI to implement and evaluate training programs for providers to support self-management approaches to patient care, which we'll hear about in detail on today's webinar. We're also joined today by Dr. Michael Vallis. Michael is a psychologist and lead of the Behaviour Change Institute at Capital Health, now Nova Scotia Health Authority, as well as associate professor at Dalhousie University in Halifax, Nova Scotia. We've been fortunate to work very close with Michael as an improvement coach, coaching teams on self-management support as part of the Atlantic Healthcare Collaboration here at CFHI. So welcome, Michael. We also have our producers, Sheena Powell and Kelly Ripley, operating behind the scenes today here in Ottawa, along with my colleague, Jen Verma, Senior Director of Collaboration for Innovation and Improvement, who was instrumental in leading the development of the Atlantic Healthcare Collaboration back in 2012. So over the course of this three-part series, we will hear from 4 Atlantic improvement teams that designed, implemented, and evaluated initiatives to improve chronic disease care through self-management approaches to patient-centered care. Here's what we've set out to do. Demonstrate solutions for making the shift from disease-oriented care to patient and family-centered care that meet people where they are. Profile the experience of teams scaling their improvement projects and spreading them across delivery systems. And assessing strategies for motivating the clinical front line to make disruptive change to improve chronic care for patients and families. In today's session, we're going to focus on self-management support and strategies and lessons learned from the Atlantic Healthcare Collaboration teams who have worked to apply this approach to their everyday work. First, we'll start with an overview of current challenges to providing self-management support, as well as look at lessons learned from applying self-management support strategies from both an organizational and collaborative level. We'll drill into a case example from one AHC team that will demonstrate the process that was undertaken to design, implement, and evaluate their improvement projects around self-management support. And we'll finally talk about some of the strategies for enhancing skills and capabilities to motivate healthcare managers and frontline clinicians to make change and engage patients and families in healthcare redesign and delivery. In Atlantic Canada, people live with greater risk factors and higher rates of chronic disease than the average Canadian, and health system costs have historically risen faster than other parts in Canada. Given the burden of chronic disease in Atlantic Canada, there has been a need to find innovative approaches to supporting patients and managing these conditions. In 2012, CFHI began addressing this need through the signing of a charter with all Atlantic Regional Health Authorities to carry forward improvement initiatives that focused on patients and families, and was driven by a diverse network of teams and senior leadership to create sustainable changes in the way care is designing and delivered in the region. We saw an opportunity to take a collective leadership approach that focuses on best practice development and spread, ways to make best practice common practice. By establishing interdisciplinary teams to address gaps in care delivery for chronic disease, patients and families, we committed to helping to make best practice the common practice. Overall, there are 11 improvement teams as part of the Atlantic Healthcare Collaboration, 5 in Newfoundland, Labrador, 2 in New Brunswick, 2 on Prince Edward Island, and 1 in Nova Scotia. The one improvement team in Nova Scotia was agreed upon through participation of all district health authorities, which make up now Nova Scotia Health Authority in the province. I'd encourage you to visit our website to learn more about the 11 improvement projects, the teams, the CFHI faculty who were part of this collaborative, mentors and coaches, and staff who were all involved in this innovative pan-regional quality improvement collaborative. So why are we focusing on self-management support in today's webinar? Let's start by considering this. Family physician and researcher Claire Liddy, based here in Ottawa at the Briere Research Institute, tells a very compelling case as to why chronic disease is the country's biggest healthcare problem. More than $80 billion is spent on healthcare costs annually alone, not to mention other losses in productivity and what it means to the health and well-being of patients living with one or more chronic diseases, as well as the family caregivers and the healthcare providers who help care for them. Given the burden of chronic disease in Atlantic Canada, there is a need to find innovative approaches to supporting patients in managing these conditions. Self-management support is well known to help alleviate the burden on patients, families, and providers alike. But we often don't hear how these programs are implemented, with what results, and there's particularly little sharing of information on how it works when people have multiple diseases. You'll surely recognize this diagram as the chronic care model, but here's the takeaway. The McCall Center for Healthcare Innovation, which created this model, is now referring to this as the care model, because that's the world we live in today. More and more people are living with long-term conditions requiring a system that meets their needs. This is how we need to care. Self-management support is a key part of that, along with delivery system designs that involve teams of professionals working together and with the support of decision aids and information systems. Dr. Ed Wagner and colleagues at the McCall Center cite several deficiencies in how we currently deliver care that are keeping us from delivering the care model. Those deficiencies include rush practitioners not following established practice guidelines, lack of care coordination, and also lack of active follow-up to ensure the best outcome. As well, patients and families are inadequately trained to manage their illnesses. 7 of the 11 Atlantic teams focused on improving self-management as part of their initiative. In some ways, they were trying to test this hypothesis. Will more effective primary care improve the quality and reduce healthcare costs? At a recent symposium on chronic care, Ed Wagner said that doing more of the same will not work. Transforming care requires moving from a reactive sick care model to one that prioritizes prevention, follow-up, and whole-person care. I'd like to now turn to Michael to begin today's overview of self-management of chronic disease. Michael, over to you.
I've been involved in this initiative since its beginning, and what's really important, I think, for us to emphasize is that we have an opportunity to, for the field to benefit from the work that has been done within this project. And so this series of webinars is really designed to facilitate that translation, and so that we don't have to reinvent the wheel. I think we've been able to learn some things that are really quite important. And today we'll sort of launch into that series. And so I'm going to present my part of this in 15 minutes. And the reason is that we have agreed that we want to leave a lot of time for conversation. So issues that I'm going to touch on today are really going to pique your interest, hopefully, because remember one of the things that Megan said, disruptive change. But nobody likes to be disrupted. So how do we actually make this happen? And what I'd like to do is take a couple of minutes and really talk about what does self-management support really mean. And so this is really what are the issues for us who are interested in developing and implementing programs that will lead to behavior change. What are we really getting into? And so I'd like to sort of walk us through this and just imagine the following. So a patient presents to a clinician and says to the clinician, I think I probably should stop smoking. Now, the typical clinician response to this is, yay, great, this is good, this is positive. So the typical response would be for the clinician to say, okay, what about a quit date? Let's think about NRTs. Can I give you a brochure? And before you go, here's a helpline number that you can call. But I want you to think about commitment to change. And I want you to think about that expression that the clinician is so excited about. I think I probably should stop smoking. Now imagine that that same statement was made in the context of a relationship between two people that were dating. And the one person said, I think I probably should ask you to marry. Would the response be as enthusiastically yes? Or would the person in that situation, because they're invested, be thinking, there's no commitment there. You said I think, not I know. You said probably, not definitely. And you said should, not want. So what this would tell us is that we need to really understand what does change really mean. And that if you think about this scenario, a patient who says, I think I probably should, and if you had to wager your own money, would you predict that person to be successful or not? Most of us would say, when we look at that, we're not going to think that person's going to be successful. And if that person is unsuccessful, what's the most likely word that they would use to describe that unsuccessful outcome? They would consider that to be a failure. And how many times can a person have a failure experience before they conclude that they are incapable? So the point I'm starting with is that if we're not careful, our initiatives to try to help people change might actually be more challenging than we think. And so this tells us that we need to shift. I'll just show you this paper. I published this paper last year. It's called Are Behavioral Interventions Doomed to Fail? Challenges to Self-Management Support in Chronic Disease. So anyone who's interested in a reference there, this can be potentially useful. And so the context really is some outcomes are directly produced by the behavior of the healthcare provider. Think about the surgeon in the surgery suite. Think about the emergency room physician, the EMT at the roadside. And that when you think about the implications of the role of patients in those situations, then in fact it's appropriate for the patient to be passive and compliant because they're really just along for the ride. The outcome that's going to reduce burden is in the hands of the healthcare provider and what that person does. But when it comes to chronic disease, we know that that scenario does not apply. The outcomes that we're seeking are directly related to the choices that a patient makes outside of the clinic office. And so the implications of this is that the clinician needs to switch to a role that's not based on their expertise, their evidence, their recommendations, but is one that is much more collaborative and accepting. And so this is the challenge that we face. Similarly, we believe that there's a need for disruptive change because of the issue of complexity, and that much of the biomedical knowledge that guides us is actually based on a simple system, not a complex system. So when we look at systems, we can think about them in two dimensions. To what extent do we understand what's really going on? And to what extent do we agree with what one does in this situation? And in some circumstances, where there's a high degree of understanding and a high degree of agreement, this is where clinical practice guidelines, this is where algorithms, this is where reductionism is really helpful because it describes a simple system. But then there are systems that have very little understanding and very little agreement, and we call these chaotic systems. But I would suggest that most of what we're talking about when it comes to chronic disease management fits somewhere in the middle. And so it's really what are known to be complex systems. And complex systems are characterized by having fuzzy boundaries, not rigid boundaries, internalized rules that can never really be known with certainty. They're adaptive systems and they have subsystems inside of them. Tension and paradox are natural and not resolvable. the more money you spend on something, the less money you have to spend on something else. And that the interaction leads to continually new and emerging behaviors. And look at what technology is doing for health outcomes, so that as we start to work with technology, we're discovering that there could be some potential positive, potential negative effects to that. So the reason then that we need to be really mindful of us as providers and our philosophy is because there's a tendency that we have to operate within a reductionistic model. And this slide really illustrates why reductionism actually doesn't work. And this is a fairly well-known slide that describes really what we know about obesity. And so you can see here, this is really, really complex. And yet we know that there are issues associated with social psychology, individual physical activity environments, individual physiology, physiology in general, food consumption, food production. These are complex systems that interact and reverberate around each other. So this is the space that we need to occupy. And yet the context that most of us will begin with and tend to operate from is really characterized in the following exchange. It's the provider that makes a recommendation to the patient very confidently, because this recommendation is based in the context of their expertise, their knowledge. And yet patients aren't so excited. So recommendation doesn't go over so well. And so this is like, now what do we say? So really this interchange is very, very common. And change requires us to embrace a shift. And this is the most common response to recommendations. And you can see that they usually don't go over so well. And so recommendations don't work because humans are humans. And what that means is that usually the idea to change comes from a provider. The work of change comes from the individual. So it's not their idea. Humans follow their own ideas much more vigorously than they follow other people's ideas. And that typically the excitement about these clinical practice guideline recommendations isn't so strong. And so we know in general change is hard. And when change comes from somebody else's mind, not from ours, it can be even harder. And so this is an important slide that I'll spend a fairly minimal time on, but I need you to know is an extremely evidence-based slide. And this is what we call the Circuflex model that helps us to understand how people stay connected. And so there are two dimensions that define interpersonal functioning. There's warmth or affiliation, agreeableness, and there's dominance. And what is important about these two dimensions is that if you connect to somebody, that people stay connected in a way that we define as complementarity. But notice that when one is dominant, the only way to stay connected to that person is to be submissive. Because if you have two dominant people, you have conflict. If you have two submissive people, nothing happens. So in the relationship dynamic, if one takes the role of dominance, now read expert for dominant, then the other person will become submissive. And in a nutshell, that's why citizens don't tell clinicians the truth. They tell clinicians what they think they want to hear, not what they are actually experiencing. On the other hand, if we connect on the dimension of affiliation, that is, I'm not here to control you, I'm here to engage you in a conversation, I'd like to understand the choices that you make, and I'd like the opportunity to talk to you about other choices. Would you be okay with that? Then actually friendliness begets friendliness. So there's something very important about this from the perspective of human relationships. Now let's talk about where we come from, where we're rooted. And so this is in essence, the core of what we would call disruptive change. Medical competencies are really defined as the expert clinician with the uninformed help seeker. And now this is quite appropriate. It's based on scientific rigor, evidence, guidelines, and reductionistic knowledge. And it leads to really two kinds of connections between provider and patient, and those are recommendations and education. And one of the things that we know from the model that I've really just presented is that telling, which is recommendations, and teaching, which is education, they work well in those simple systems that are reductionistic, where the outcomes are directly controllable by the patient, or when the patient is ready to change. But if the patient isn't ready to change, then this expert-based model might not really be the best way of supporting behavior change. And self-management support requires not expertise as much as it requires collaboration and empowerment. And so where do we go then? And what I would recommend is that the alternative to this diagnosis, treatment, and measure outcome perspective, the expertise model that we take, is to shift to a model that's based on description. So it's not your job to tell the person what's wrong with them, but it is your job to understand that person and get some sense as to how did they get to where they are, description. Then to engage people in a sense of, well, what happens next? What are the predictions based on the choices made? And that leads into a negotiation of choices that the individual might consider to lead to different outcomes. So what you have here is really, it's not your job to make people change, but you can help change if you understand the current behavior. It's important to recognize that as we support people in working with the consequences of their choices, they start connecting the dots, and that can be extremely motivating. And importantly, we know that in the healthcare system, patients want to know what the providers think. So choice is important, but they don't want to be told what to do, so they don't want to let go of control. So we believe that this is a model that can be facilitative. And in essence, what it means is that we shift from diagnosis, treatment, intervention, outcomes rather, which we measure. And when you take this perspective, those are dependent on how good we are. We replace that with description, prediction, and choice. And so the problems with diagnosis and assessment in a complex system is that it can lead to labeling. The problem with treatment is that it leads to the language of compliance. The problem with measuring outcomes is that we get invested in these outcomes and then we get judgmental as a result. With description, we just simply engage the person in an open conversation where we're not threatening their choices. Now the change-based skills that we recommend, and you'll see how these are implemented as you see these projects be described, would involve developing relationship skills, that is establishing what we would call a change-based relationship using motivational communication strategies, assessing readiness to change and promoting readiness when it's not there so that we can get to the behavior change skills that help people make changes that are likely to last, and then the emotion management skills, that is, how do the new behaviors we promote fit into the psychosocial context of the individual. So I'm going to stop there, and what I've done is just tried to put a foundation stone for what you're going to hear next. I'll pass it on to my colleague Donna, who will take you through her presentation, and then we will have lots of time at the end where we can circle around and talk about this. Thank you.
Hi, and thank you for that, Michael. My sound okay?
Sounds good.
Okay, thanks. So thank you very much for the opportunity to present today. This has been a work of passion for Health PEI, which is certainly looking at focusing on more supporting self-management change with clients as a partner in their care. So first I'll just give you a little bit of context for the problem. We already know that the environmental factors that encourage unhealthy behavior are well documented. That includes our sedentary lifestyles as well as reliance on fast and high-fat foods. Dr. Vallis also speaks of socio-biological factors that challenge us, and we saw that in that fairly convoluted-looking diagram. We also know that humans are physiologically geared to seek pleasure, to choose the path of least resistance, and to prefer short-term gain regardless of long-term consequences. So in 2011, Health PEI did an island-wide primary health care survey, and we received about 12,000 responses. Approximately a quarter of those folks with chronic conditions who responded said they were rarely or ever able to participate in their care plan or were aware of what they had to do for follow-up after an appointment. The responses really indicated that health providers need effective ways to introduce and support behavior change and help clients to find a new normal that includes healthy choices. So Health PEI is focusing on reducing the risks for chronic disease by supporting self-managed care. and that really means engaged and activated patients, as we saw in the care model. The plan is to equip clinicians across the province with the strategies and skills to support their patients in making lifestyle behavior changes. The intervention that Health PEI is using is something called Supporting Realistic Behavior Change. It's a training package that was developed by Health PEI, the Department of Health and Wellness, and Dr. Vallis to build the capacity of Health PEI to respond to the current and growing burden of chronic disease through a minimal intervention approach. So minimal intervention is a term that we use for a set of skills that's intended to be used by health providers who typically have only a short time to work with clients to promote health behavior change. And as we know, exchanges in health are often very time limited. So the intervention is really about persistently checking the readiness of patients to make changes and support those changes, regardless of how small they are and whenever the opportunity presents. It is based on well-established behavior change theory, including Prochaska's stages of change, the 5 A's, which are ask, advise, assess, assist, and arrange, as well as the 5 R's, relevance, risk, rewards, roadblocks, and repetition. The realistic in the term supporting realistic behavior change is really about being realistic from the patient's point of view. Where a clinician may see the goal as exercising, the patient's goal may be being able to breathe. So telling a patient who can't breathe to get out and walk probably isn't going to work. Paradoxically then, to change patient behavior, we have to begin by changing how clinicians behave with them. And you heard some of the supporting documentation from Dr. Vallis. We really need to build the provider's confidence that they can change the way they practice. They are shifting to a new approach, to guiding patient visits rather than giving directives. And they have to be curious and open to what's keeping patients from changing. They're shifting from giving guidelines for healthy living to encouraging patients to get involved in a discussion about their choices. The team that we had working on development of this intervention, it's supported by Health PEI leadership, so that's at our executive director level throughout the province. We also had a provincial steering committee that was made up of a project sponsor that included our executive director as well as directors in acute care, home care, primary care, mental health and addictions, and public health, as well as a representative of the Department of Health and Wellness. And the Supporting Realistic Behavior Change Initiative, it's really an excellent fit with Health PEI's focus to support self-management of chronic conditions and person-centered care. Sustainability is really enhanced with continued support from leaders and management in the system. We do check in on a regular basis to let them know how the program's going, what the outcomes are to date, and getting renewed support. So that really helps move this forward. We did have a measurement plan in place. So for facilitators and participants in the training, we want to look at satisfaction with the training experience, acquisition of the knowledge and skills, the self-efficacy of the facilitators and participants, that is their confidence about what they've learned and their attitude, of course, toward the content. For participants, we also want to measure improved system and provider practices. And for clients and patients, we want to look at lifestyle behavior change, self-efficacy to make the changes, and their experience of care. So in regards to outcome and process evaluation that we've done, we looked at a comprehensive outcome and process evaluation protocol. It was comprised of delivery, that is the extent to which the intervention was implemented as planned and the extent to which the participants were satisfied with the training. We looked at fidelity and quality, the extent to which participants felt confident in their ability to use learned techniques in their practice, as well as their actual use of the skills in their practice. We looked at context, which is around improved system and provider practices through an environment conducive to enabling participants to implement their training techniques. And we also want to look at benefit to patients and clients, look at improved attitude, cognitions, and behaviors of the patients and clients following their health providers engaging in the training sessions. We still have yet to do the last piece, benefit to patients and clients. We are looking to make sure that we train out on a critical mass for providers before we make that endeavor on a provincial basis. Some of our key results to date: we have 9 peer facilitators, primarily situated within community-based services at this point in time. We do have a few in the acute care sector, and we will be looking to build capacity there. And we also have 130 participants trained to date, with 60 more scheduled, and those folks are in community-based services. We've just initiated some discussions to make sure that we're getting buy-in from managers in the acute care sector so that we can move that work forward. And as I already mentioned, we already have a couple of peer facilitators in acute care, but we'll be building capacity to train out there as well. During the training sessions, participants were able to identify a couple of changes they would make to the practice. So identifying and being curious about the barriers to change is a big one. We don't often ask our patients, what is it that keeps you coming into hospital? What is it that keeps you coming back to the ED? What can we do to change that? Instead of giving guidelines for healthy living, once again encouraging the patient involvement in the discussion and allowing their choices to be heard and accepted. We do have staff on a regular basis who are asking for the training, so I think that speaks volumes about the training itself. Our goal is over the next few years to have all health PEI healthcare providers, about 1,000, taking the training over that time frame. Just a little bit about what we've heard as testimonials from practicing clinicians. The improvement is making a difference. We are hearing that. As a clinician who has embraced the approach in their practice, they tell us that it helps guide and define the patient visit, gets to the key health issues by identifying and naming the actual elephant in the room without shame and blame, and it helps build the relationship and builds on previous patient accomplishments, no matter how small. The initiative also fits well with other learned competencies such as specific disease care, hypertension clinics, COPD clinics, and it should really be integrated into basic training of all clinicians, and we are actually looking at the opportunity to do that. It can be used in all conversations with family, friends, colleagues, and patients, and it's really about patients taking ownership for managing their own health. One of the testimonies that we received from a patient who was engaged with a provider who truly practices supporting realistic behavior change, really this individual said, my nurse is a partner on my journey, so very much involved with supporting the patient to make the trek. Some of the key learnings that we had out of our initiative was support from leadership and management is absolutely key. They need to support the process and the approach. It is really an expectation that this training will spread to all clinical areas within health PEI. And supportive managers, they really help run interference with other providers that have not yet bought into or are not yet ready to change. We do also have to look at the readiness to change for providers. We've also spread the cost for this training across all program areas, so it isn't considered a burden for one particular division of the organization. This training also gives healthcare providers permission to do something that's not traditional, so you also need that added support from management at the site as well as other practicing clinicians at the site. We also communicated the training as a professional development opportunity. We offer out certificates of, number one, participation. So that is for anybody who receives the training, they can get continuing education credits, but we also offer kind of a competency certificate. So if individuals who have taken the training can provide demonstrated proof that they're actually using these approaches in their practice, we can provide them with a certificate of competency of use of the training tools. So the communicating the training as a professional development opportunity, instead of looking at it as changing traditional practice, tends to meet less resistance. We also started with keen adopters, and obviously we all appreciate the need to look at the low-hanging fruit these days, so that's really important. And we're delivering it out over time, so we understand that we want to spread this, and it would be really nice to do it all in one quick and dirty flash, but that's not going to happen, and sustainability I don't expect would be as relevant to us if we did it that way. The initiative obviously represents a behavior change for providers, and it's really with an intent to change behavior of clients. And as we've already spoken about, change is obviously never easy. So it does take time, and it does take effort, and it does take continued focus and momentum by somebody who can keep pushing the envelope as needed. And I think that's it for the moment. I look forward to any questions that folks might have. Thank you.
Wonderful. Thank you, Donna. Thank you, Michael. So folks, just a reminder that we have the chat box open for your questions for Michael and Donna. So while we wait for your questions to trickle in, I do have a question that I'd like to ask, but first some background. So self-management support is a critical part of the chronic care model, and Ed Wigner said to us he thought it was important that we focused our Atlantic Healthcare Collaborative efforts on self-management because from an outcomes perspective, engaged patients are better able to manage their health more effectively, leading to a better symptom management and outcomes. So Michael and Donna, you talked about the kinds of skills providers need to help people self-manage. So often people focus on behavior change skills, but how can providers gain skills in relationships, motivational, and emotional management? Perhaps Michael, I'd like to hear from you first.
Thank you. That's a great comment because one of the things that we know would be the following. Tools without theory are at risk of becoming weapons. So when we think of behavior change strategies, that we know these can be evidence-based strategies, but what's really important is that self-management is really about the choices that an individual makes. And so realistically, when a citizen leaves our health services and goes back into the world that is their life, they're only with us for very brief periods of time. So in fact, we are close to being insignificant specks in our patients' lives. Then what we really hope for is that these individuals will make choices in the context of their daily lived life that will be consistent with our recommendations. And so what this really reduces itself to would be the following question. I ask patients this question in my clinical work, and I would encourage anyone to support the question being asked in any other context. And that question is as follows. Provider to patient, why would you listen to anything I say to you? Because in fact, it's that relationship between the healthcare provider and the individual that is the conduit for self-management and therefore self-management support. So we might think that, oh, these are nice behavioral tools that are evidence-based and they're standardized, but it's the relationship because what we need to do in essence is promote an answer to that question, why should you listen to anything I say to you, that promotes a response that's based not on because you're the expert, because your expertise will fade when they leave your office, or not an answer that is because I know I should, because that's not really what drives humans, but an answer that helps people to bring out their personal, meaningful reasons to change. So change really comes because the individual chooses to change, and their ability to choose those change and then make use of those tools is very much connected in their motivation and their readiness, and that requires a relationship with healthcare providers to promote that.
Wonderful. Thank you, Michael. Donna, turning to you, would like your thoughts on, from your experience from Health PEI, how providers can gain skills in relationships, motivational and emotional management.
So people have emotional and relationships every day in the workplace, but one of the things that we do know is that all of this really is foundational on building a good relationship and trust. And we do know, we've heard from clinicians on a regular basis about those revolving door patients. And just to speak to a bit of an example, we've recently had somebody join us who originally worked in the acute care setting, has joined us in primary care, and she certainly had a big aha moment when we had her participate in supporting realistic behavior change sessions, and she now actually is a true practicing clinician in that field. What she said to me is, she said, you know, when I go back to work in acute care, she said, I'm going to challenge my colleagues to actually ask the client what it is, what the obstacle is for them to really sustain their health and stay out of hospital and stay out of EDs. We don't often ask that question well enough, and we often make a lot of presumptions that they are issues that are very medically focused, and that's really not the case. We quite often hear about solutions directly from the clients that are very much more based on social determinants of health. So if we put an individual on a medication for whatever, say diabetes, but the individual really can only afford to either buy chem strips or to purchase their medication, they're spreading out their treatment option. We need to find out why that's an issue for that person and how we can help them overcome that obstacle. We really need to build that relationship and trust, and I truly think it's really around identifying what it is the person wants to make a change in and identifying their readiness. And if they're not ready today, we need to check in with them on a regular basis to find out if their readiness status has changed. We do have some tools that we offer out for the supporting realistic behavior change, and that is the simple traffic sign. So we've got a green light, yeah, patient says they're good to go, they want to make this change, they've got the resources and the supports to do that, or yellow, I'm not sure, I'm a little ambivalent, I'm kind of on the fence. Well, we don't want to pull them onto this side of the fence, but we do want to check in with them on a regular basis to see if they're leaning a little further this way to make that health behavior change. I don't know if that gets at your question there.
That's great. Thanks, Donna. So we've got some questions trickling in here in the chat box, which is great. First one comes from Elizabeth French from Alberta Health Services, and she's asking if we can suggest some good resources to improve our motivational interviewing techniques. So Donna, perhaps we'll start with you for this question.
Well, actually, I was going to refer them back to Michael. He's the psychologist with good resources. Certainly, we've developed a package pulling in. I already mentioned some of those resources: Prochaska's Stages of Change, taking a look at the 5 A's and the 5 R's. Those are what we really based our supporting realistic behavior change training packages on.
This is Michael. I'll make 2 comments if I might. The first is I've just posted the Behavior Change Institute website, and so there's a potential resource. But my other comment to you, Elizabeth, would be look for your local resources. So this site can help guide you in some strategies, but what we do know, and I see that you're from Alberta, and I've actually spent some time in Alberta doing some training. And so one of the things that we really want to do is encourage the idea of collaborative communities of practice. So who are the people within your system who have more rather than less familiarity with these models, and how can they engage us to review some of the skills so that what we try to avoid in the Behavior Change Institute is being perceived as, oh, we're the experts and we know all the answers. And what we try to offer is that, no, we're the collaborators who can put onto the table some of the principles, and that those can allow you to go forward. And if I might, Megan, I'd like to just get to the next question as well, because it's right on the heels of this point that I've just made about principles, not methods. And so, Carlin, you ask about brief action planning, and is that different or the same? It sounds similar. It's absolutely identical. And so what we try to encourage from the perspective of supporting sustained health behavior change is for providers and systems to access tools and resources that have theory behind them and evidence, and then the method follows from that. So a brief action plan would be the same as a goal-setting intervention, or it might be the same as the principle behind, let's say, conversation maps, etc. So when we see those kinds of issues, what we ask clinicians to do is think about, okay, what does that brief action plan address from the perspective of relationships, motivation, behavior, and emotion, and then how do we embellish that tool? So it's a great approach, and it's very much evidence-based. So it's actually not different at all, and so then there's no reason to change it because it accomplishes something very specific. What we try to encourage is the perspective of, okay, what can we get with this tool? How do we use it properly? And then how do we link it with motivation, relations, and emotion?
Wonderful. Thank you, Michael, and thank you for fielding that question. Also another question coming from BC, Rachel Douglas with Fraser Health. She says, this is a great project that pulls together what we know from psychology with what we know about how systems work. In our region, we also need to add a cross-cultural layer in a context where language barriers may be in place. Are you aware of any literature about programs that help weave this in? So Michael, perhaps you'd like to field that one as well?
I would, yeah. And thank you so much for that, Rachel. I think the informed answer is no. We really don't know that yet. This is, and it may be that this is something that's similar to the issue of cultural sensitivity, which is we won't ever come up with the compendium of cultural sensitive methods. But what we have to do is take those principles and layer them on to the culture. So this is actually a really important point. And I know that Patrick McGowan at University of Victoria is very interested in his model of self-management support in looking at some of those cultural and cross-cultural layers. What I invite people to do, so someone like yourself, Rachel, I might invite you to take some of the sort of theoretical principles that support change that are not culturally specific, and then with your experience of what those cultural specific issues are, how do you then collaborate with your patients so that you co-create a culturally sensitive way of implementing these skills? And so that in some ways my hope is that this is the test of complexity theory, where it won't be so much that we'll be guided by literature that can capture the complexity, but that we'll be able to create a plan. And if you think about the issue of multiple medications, there is absolutely none, I can guarantee any of our patients who are on more than 4 medications, there is no randomized trial showing the exact combination and permutation of the medications that they're on. So here would be the common situation of polypharmacy, where we have no literature to support the interaction between drug A at dose A times drug B at dose B times drug C at dose C times drug D at dose D. And what we have to do is then we have to work in that individual context. So it may be similar to that, in which we use those cultural contexts to inform us as to how to adapt. And that's actually very consistent with empowering individuals, respecting their expertise and their wisdom, and then in collaborating to move forward.
Thank you, Michael. So I'm actually going to skip down a little bit to a question from Douglas House from the Newfoundland and Labrador Department of Health and Wellness. A question for Donna. He's asked, has Health PEI introduced any provider incentives to either participate in training or implement minimal interventions into their practices?
It's Donna speaking, and no, we have not. We are really concerned, as we are with all incentives to providers to perform what we think they already should be doing. Our concern is really it gets to be a bit of a slippery slope. What do you want to incent people to do? We do know that there is at least a third of the population. It's the third rule, right? A third of the people are really they get it. They know that they need to practice differently if they want to support the patient to actually make changes in their day-to-day life. We know there's another third that are probably on the fence, but we also know from the training that some of those folks, the third in the middle that were on the fence, are taking a look over and saying, I'm seeing that the revolving door is either slowing down or stopping. Maybe I need to consider doing something different. We also know there are some providers who will never want to practice this way. That's very unfortunate for the clientele that they look after. But no, we don't provide any incentives to participate in the training or implement minimal interventions into their practices. We do have we always choose a sponsor who is typically a manager in one of the community-based service areas who sponsors the training, so they offer up nutritional snacks, but that's pretty much it as far as an incentive goes for participating in the training.
This is Michael. I'd like to make a comment and just maybe comment a bit about what you've just said, Donna, because I have been involved in supporting the work that Donna's described from the beginning. And one of the things that I can say about the PEI approach that has been so amazingly helpful, and I think what's been really foundationally important for the success that they've been able to demonstrate, is that they have real commitment from the Department of Health. So they were very serious at a high level of the really embracing this concept and supporting it. And so my comment really is that I think that managers and administrators and decision makers really need to do more than pay lip service to behavior change, because I do believe that they can set the tone that will allow then the initiatives to go forward. And I think it will grow, as Donna is saying, from a social consensus point of view once the results start to be seen. But I think an important element really is that system, high-level system, serious commitment to change, which was really, really nice to see.
Thanks, folks. So, Michael, I'll just direct a couple questions your way as we near the end of the session. So, Shauna has asked, how do you encourage whole person care balanced with disease-specific care while still ensuring optimal health outcomes? And a second question coming back from Carol. She's asked, have you come across these competencies, those ones you're speaking to, in job descriptions? So, two questions there for you.
Perfect. I can deal with Carol's question quite quickly, and that is that this is a big challenge, and one of the things that we're trying to really push at the Behavior Change Institute right now, which is how to define and measure competencies in these skills. So that's an area that we've really taken on from a perspective. I will tout the horn of my organization, though, because they've begun to address this. So I'll just describe to you very briefly the concept that we have here. We have what's called a community health team, and this is a resource for citizens that can access directly, so it's not a referral-based system, and that the providers who are employed within the community health team are not chosen on the basis of their training or their designation. So we do not recruit for nurses or psychologists or social workers. We recruit for people who are like wellness facilitators or behavioral change agents. So we actually define function, and then we hire people, and it's not so much competency-based because we don't really have that evidence yet to measure the competency well, but it certainly is the consistency with the orientation. So someone who was really very expert-based, very much a reductionistic type of person wouldn't really meet the criteria for the philosophy behind the team. So we're beginning to see that happen. In terms of the question of whole person, while still ensuring optimal health outcomes, thank you so much for that, Shauna, and welcome to one of the biggest barriers to self-management support. We are not responsible for the health outcomes. It's the citizens who are responsible for the health outcomes on the basis of the choices that we make. And so we very much need to be aware of this balance between the whole person, their specific disease issues, and their outcomes, and that we need to live within the tension that gets created between that whole person focus with the specificity around a disease in the context of outcomes especially with diseases where the outcomes are very, very delayed. So if you think about cardiometabolic disorders, where it may be 2 or 3 decades before you really see some of the negative consequences. And how can we achieve disease-specific outcomes when the whole person might take us in another direction? And this is part of that tension that exists with regard to behavioral support, which is it's the relationship we have with the patient, and so we can only go as far as the patient is really ready or willing to go. Now, as Donna has said to you, by doing a readiness assessment, we believe that what we can do is identify, importantly, the situations where people are not ready. And what's important about that is that we do not stop treatment when they're not ready. We just switch the treatment, as she has implied, away from here's what you need to do towards what are the barriers that are interfering with your health and how can we support you. So we very much try to resolve that ambivalence and move forward.
Thank you, Michael. Donna, would you have anything to add?
No, I think Michael's covered it quite amply. Certainly, I will let you know that every one of our facilitators actually practices this approach in their own clinical practice, and they are all clinicians. So they really have firsthand experience, and they do draw experience from the participants as well during the training. So they really do get down to those real cruxes that clinicians run into when it's, well, I really want to tell them to do this, but we know that's not going to work, so what approach do we take? And it's really about problem solving amongst the group and throwing out those really difficult questions or situations and asking the group to help identify how you can kind of tackle those during your short period of time that you have to actually help with interventions with the client.
Thank you, Donna. So as we come to the end of this webinar, I would like to invite you all to the next webinar session in this series. So on November 25th at 12 p.m. Eastern Time, we'll be talking about lessons learned from 3 other Atlantic Healthcare Collaboration Improvement Teams, which includes Western Health from Newfoundland Labrador, Horizon Health Authority from New Brunswick, and the Nova Scotia Health Authority, formerly known as Capital Health. The third and final session for this series will take place on December 11th at 12 p.m. Eastern Time, where we will explore CFHI's approach to evaluating and capturing key results from the AHC Quality Improvement Collaborative. You'll also see a list of other upcoming free on-call webinars coming up in the next few months that we hope you will take advantage of. You can see our full list of offerings at our on-call website at the link provided there on your screen. You should have also received information from CFHI on how to access additional resources related to this call. If you have not, rest assured we will recirculate this information following the call. If folks could turn their attention to the polling questions on your screen, we're just going to ask that you take a moment to fill out the survey. While you do this, I'd also like to thank both of our speakers, Dr. Vallis and Donna McCausland, for their excellent presentations today, and for our producers, Kelly and Sheena, for working behind the scenes to make this webinar happen. Michael, Donna, I'll also invite you to address any closing remarks or any final responses that you might have.
I'll just make a comment that we heard there's one of the people posted about choices and change, and I would just again make a plug for that as well, that this is another evidence-based strategy, and that when we think about the task of self-management support, we as clinicians need to avail ourselves of the resources that are out there. So I would just highlight your attention to the comments that were made about choices and change. Thank you for that.
And Donna?
Just that we're fairly passionate about moving forward on this, and we have several other activities on our to-do list around developing patient awareness materials, really pushing the patients to be asking or expecting the clinician to have those kinds of conversations with them. We're also looking at refresher and booster courses for clinicians who have participated in the original training and working on practicing that, and a community of practice or support network for those practicing facilitators and clinicians, because they often run up against some special questions or situations they're dealing with their patients, and having that support group around them is really important.
Wonderful. Thanks, Donna. Thanks, Michael. There was a question that was in the chat box that I know is not on the screen now, and just like to clarify that, yes, the slides from today's session will be provided. So with that, thanks to all of you for attending this session and your participation in today's discussion. This concludes today's information call webinar.